All right, it's 8 o'clock and I'll get started. Kathleen is joining shortly. We are in week 8 of Cardio-ECHO, tackling type 2 diabetes. It's so good to see you here this morning. Please put your name and your location in the chat box to record your attendance. This morning we'll go around and do some introductions. I'm Shannon Switkowski, I'm the clinic coordinator. We'll go to Dr. Rao.
Good morning. I'm Goutham Rao from Case Western. I'm the director of the ECHO program.
I'm Chris Taylor. I'm a professor of medical dietetics at Ohio State University.
Good morning. I'm Liz Beverly. I'm a behavioral diabetes researcher at Ohio University Heritage College of Osteopathic Medicine.
Good morning. I'm Jim Warner. I'm a behaviorist and researcher at Case Western University Hospitals.
Thank you and welcome. And I will turn it at this time to Dr. Dungan. I think she's back on.
Hi, and I'm Kathleen Dungan, endocrinologist at Ohio State University. And welcome to this week's ECHO. This is the structure of our ECHO clinics again. We'll have a 25-minute didactic presentation followed by Q&A. And I just ask you kindly again to please turn your video on. When you want to speak, you can unmute your microphone and then mute it again when you're finished speaking. We can also use the chat feature. That'll be followed by our case study presentation and discussion, which will be about 25 minutes, and our post-clinic wrap-up. Please remember to complete the survey at the end. All right, well, with that, we'll get started here in our Tackling Type 2 Diabetes series. These are our disclosure statements. These were sent to you by email yesterday, if you didn't catch them. And we'll move on to our didactics. So our didactic presentation today is on food sources and type 2 diabetes. This will be presented by Goutham Rao and Adam Brzezinski. I'm not sure if he was able to make it today, but he helped with the preparation of the slides. So Dr. Rao, take it away.
Thank you, Kathleen, and thanks to everyone. So Adam was not able to make it this morning. He did have an urgent family matter to tend to. However, I did review his slides, so please bear with me. I'll try to do the best that I can in order to describe his content. One word about the disclosure. I do serve on the Science Advisory Board for the Dannon Company, which is one of the largest food companies in the world, and my specific role has to do with yogurt. I have no intention of discussing yogurt or any related products this morning. So these are the 3 objectives. It deals with food sources, and I've been in this space now for 20 years, learning and trying to change things, the way people eat. But we're going to talk a little bit about taste preferences as well and impact of public health efforts to improve the healthfulness of the food supply. So next slide, please, Rick. Okay, so we don't have to get into a lot of details. We know that there are large racial and ethnic disparities in many chronic illnesses, obesity being one among them. So the highest rates of obesity are in African Americans. Then you have Latinx and Native Americans. These are all higher than the overall prevalence. This actually disguises some even more important differences, which we talked about in our last series. There are not racial disparities among men in terms of the rates of obesity. What's driving these racial disparities are large differences among women of different backgrounds. But this is all well known, and as I said, we don't need to review this information again. Next slide, Rick. So what drives these differences? Well, it has a lot to do with eating habits, and these vary not only by race and ethnicity, but by income and education. And this is just one example. I know it's a little difficult to read, but the top slide talks about trends in consumptions of healthy foods, in this case, nuts and seeds. And you can look at 1999 on the far left and 2011 and 2012. And as you can see, across the board, people with higher levels of education tend to consume more of these healthy items. But that's not what's so remarkable. It's the rate of increase. So the healthy are getting healthier. It's almost like the rich are getting richer. And that's what's really concerning. And you see that once again with consumption of whole fruit versus fruit drinks and fruit juice, which is not as healthy. And you see that the higher somebody has in terms of income, of course, they're going to be consuming more, but that gap is actually widening. And the bottom slide has to do with sugar sweetened beverages, and you'll find the same sort of thing. The higher level of education that one has, the improvement in terms of decrease of consumption of those beverages is greater than among people with a lower level of income. Next slide, Rick. So let's talk about racial and ethnic differences. We see, again, some substantial improvement across the board. We think about, well, who's drinking sweet beverages, or whether they're artificially or naturally sweetened fruit juice. They have generally decreased substantially. So we see that not only among African Americans, but dramatic drop among Mexican Americans, and an increase in whole fruit consumption. But then again, here we go. Non-Hispanic white patients tend to improve in their nutrition in this regard more than the other groups. So that is a troubling sign overall. Next slide. So why do people buy food? Why do they eat what they do? And how does that vary among different socioeconomic groups? I can't summarize the enormous amount of literature in this area, but it does tell us that what we're up against is pretty substantial. So the number one driver for anyone, despite what they tell you, is taste. People eat what they wish to eat. And those of us who have children know this for sure, based on what it tastes like. The number two driver is price. Healthiness and convenience have improved. It used to be convenience. I think everything's pretty convenient now if you look at it. So maybe that's less of a driver. Sustainability, way down the list. So we have a lot of information in, those of us who are sort of the NPR crowd about, farm to table, et cetera, et cetera. That's way down the list for our average consumer, and certainly down the list for our average patient. So taste is the number one driver. And taste is a more important driver among poorer populations and people of color. There are differences among taste preferences, which I was just reviewing last night. The racial differences in taste preferences, which people have tended to highlight, are relatively small. The big difference is between men and women, males and females. Taste preferences are established in utero, so it starts very early. And I remember being in Philadelphia at the famous, I think it's called the Munsell Taste and Sensory Center, and they gave us this little experiment, and I was paired with this woman who was about 40 years old and was well educated, and they gave us these strips to taste, and she and I had the exact same strip, and she tasted the strip. You just touch your tongue to it, and she said, "Oh my God, that's so bitter," and I could not taste anything. So women experience taste much, much more intensely than men do for a lot of reasons. And that may be one of the explanations for differences in obesity prevalence. If you like something, you're going to taste something. If it doesn't taste that interesting to you, you're probably not going to eat as much of it or indulge in it. And those are the kinds of things that people are looking at these days as what drives taste preferences. And I would love to talk to you about all the research in this area going on at that corporate entity that I consult with, but I won't do that right now. Next slide, please. So the other thing, I think the core principle is that access is a very difficult thing. We should create healthy food environments for our society, and especially for our patients who are economically challenged. And Adam has a lot about this, and I'll get to his slides in a moment. But just because you give poor people healthy food doesn't mean they will buy it and eat it. In fact, it probably means they won't. And there was a very famous natural experiment. This is going back 25 years. It took place in Burlington, Vermont, not a community known for its diversity, but nevertheless, it has a very large food bank. And the food bank received regular contributions of regular white bread, which cost $1 per loaf every single week. And one week, this artisan bakery said, "Hey, we'd like to contribute to the food bank. We're going to contribute some very high-end bread that we sell for $5 or $6 a loaf." And they put it just next to the white bread. So there is no cost or convenience factor involved, right? It's all free. They're equally convenient. Almost none of the food bank customers chose the artisan bread, even though it's healthier. So it gives you an idea of some of the forces that we're up against, because we have to battle the issue of taste preferences. The other natural experiment was, I came here from Chicago, and there was a lot of talk about healthy food and close to the Hyde Park campus at the University of Chicago. So finally they put a Whole Foods there and said, wow, isn't this wonderful? People in this area now have access to the healthy food. Whole Foods is very expensive. I've been in that Whole Foods many times. The only people I see there are faculty members of the University of Chicago that I recognize. So that's not doing anything. Now, there's other benefits. There's the idea that you have an employer, et cetera, et cetera. I'm not discounting those benefits at all, but it really does not seem to do anything. And there's a growing body of literature. And if we can have the next slide, this is a more comprehensive report. We built it, and they did not come using governance theories in the fight for food justice. Is it detrimental to lobby in this area or not? I still think there is value in creating a healthy food environment, but do not expect this to reverse any of the trends in chronic disease that we are observing right now. We need a completely different approach that takes advantage of the food environment and steers people in the right direction. And that has to involve public policy. Next slide. So this was my effort, which failed. So in 2014, you may remember, as part of the Obama administration, the First Lady, is a wonderful person, very passionate about this issue, took on children's nutrition as her topic. And I testified in Congress. The idea back then was to regulate what are called competitive foods in schools. So, if you have children who go to school, there is the USDA approved lunch, which is less palatable. The USDA approved lunch is less palatable, but it meets some nutrition requirements. But then schools are allowed to sell hamburgers, hot dogs, junk that is unregulated. And those are called competitive foods. And the president at the time wanted to regulate those foods as well, and wanted some expert testimony in this area. It did not get out of didn't get very far. And it wasn't really lobbying from the food companies. It was just more about personal choice and freedom that kind of sunk it. But it's a kind of effort, I think, that we do need to take in order to change food environments across the country. Next slide. So what do we do if we are up against taste preferences that are established in utero? The famous statement is that by the time a child can tell you what they like, their taste preferences are already set. So it doesn't really help, right? If they throw something on, if they can't talk and they throw something on the floor, they obviously don't like it, and so you're done. So I think one approach is public policy. The other one is redefining food justice. So food justice was traditionally defined in a policy paper as communities exercising their right to grow, sell, and eat healthy food. Healthy food is fresh, nutritious, affordable, culturally appropriate, and grow locally, which again is tough, with care for the well-being of the land, workers, and animals. So it's a very lofty goal and a noble goal, no question about it. Jim and I have been running the Fit or Me program for 2.5 years. And the core principle there is that getting to a healthy weight is not about what you are doing, but what you stop doing. It's not about a new diet or a new exercise machine or a new gym or something that is missing. It's what you are doing now that you need to stop doing in order to get to a healthy weight, okay? Because obesity is not the natural state of everybody, and therefore you must be engaging in behaviors that are leading to obesity, diabetes, and chronic disease. So this is just one effort to redefine food justice. You don't have to agree with it, but I've defined it as food justice involves refusing to purchase and consume unhealthy foods which are marketed and sold aggressively in poor communities and communities of color. So in poor communities, people have lobbied successfully, for example, now for voting rights, for police reform, for better housing, et cetera, et cetera, et cetera. So why do you allow McDonald's to be the only food source in your community? If there is true justice, that's something you need to stand up for as well. So it's a different way of thinking about it, rather than this more lofty goal of providing healthy food, although this may be helpful to have farmers markets, et cetera, locally grown produce. But the problem is, if you really want to reverse some of the chronic disease trends we see in poor communities, we need a different approach altogether. And we'll talk about that now. Next slide. So this is, I'm beginning Adam's slide. Please bear with me. I've emailed him a couple times and we went back and forth. And I've read the study that I thought was fascinating that he co-authored back in 2018. So for example, we see people, and this is a really a common approach we have been advocated to use in primary care. Screen and refer models help resolve individual challenges, but structural challenges and hazardous food environments remain. So for example, there was a move in primary care to give people healthy food prescriptions, vouchers for farmers markets, ideas for recipes, etc. Not really effective. It may raise some awareness of what people ought to eat, but are they actually going to do it? If they don't have the infrastructure around them, probably not. So these approaches do not address underlying characteristics of communities that place individuals at risk and limit healthy options. So there is our community characteristics plus individual characteristics that are going to counteract those efforts. I find that many of us, I'm assuming, do have relatively healthy diets and access to healthy foods. We assume, and I think there's a tinge of arrogance to it to say, okay, well, look, here's my healthy food prescription. I want you to eat more vegetables. There you go. Geez, I've done something good today. Well, it's not so simple as that for a lot of these folks. Next slide, please. So Adam and his co-authors discuss the use of this area deprivation index, which I think is absolutely wonderful. So we think about, gosh, poor communities, rich communities, we dichotomize them, healthy food environments, less healthy food environments. That's not a really meaningful assessment. In the city of Cleveland, there are people that are very, very wealthy and many that are not. Even by zip code, there are people who may have vehicles and may have white collar jobs and are doing quite well among our patients and those who are not. It's the overall proportion that gives you a better description of what a neighborhood is like. And this is what this ADI is all about. Household income, mortgage, which includes most parts of Cleveland and other cities in Ohio is relatively low, of course, at least high school education. And the better the parameters are on these things, the less deprived an area is. If you just look at income, you can imagine you won't get a complete picture. You could have a whole bunch of seniors who have relatively low income, but have lots of assets, no mortgage, are well educated, et cetera, doing quite well. Whereas if you look at all of these parameters together, it gives you a complete picture. Next slide, Rick. So this is a terrific map of Ohio based on the ADI scores, and the least disadvantaged areas, as you can see, are suburban areas of Cleveland, Toledo, Columbus, Dayton, and Cincinnati. The most disadvantaged region is Liz's region, the southeastern part of Ohio. Now, it looks like a lot of red in that area, and it is, but the relative populations are small, but nevertheless gives you as a region all the way up from Kentucky all the way to the Pennsylvania border or along the Ohio River is the poorest part of the region. Of course, there are urban areas in our large cities as well that are similarly afflicted. Next slide. So this was the paper that I spoke to you about with Dalton and Przinski and colleagues. And what it tells you is that essentially that how you predict cardiovascular risk depends on a number of things. Next slide, please. This was dealing with Cleveland Clinic data. And again, this is an ADI map. As you can see, suburban areas of Northeast Ohio are the most affluent and the inner city areas are poor. And you have those areas, not just in Cleveland, but obviously in Akron and other communities. Next slide, please. And the cruise hazard ratio deals with cardiovascular events, again, taking place disproportionately in those poorer communities. Next slide. But here's the sort of thing, the pooled PCERM is a pooled cohort equation model we don't need to deal with. The fundamental point that Adam and his colleagues were trying to make is that if you just look at things like race, income, ethnicity, smoking status, you will not get an accurate prediction of how much cardiovascular burden there is in a particular neighborhood. You have to look at the overall neighborhood index, which takes into consideration all of those other factors. So neighborhood socioeconomic alone did not account for 32% of unexplained census tract variation in ASCVD event rates, compared to 10% just based on the standard equation model. So it's the neighborhood which determines it. Now, there are some serious caveats here. Next slide, please. So here's a census tract life expectancy. Of course, we have seen such estimates. The tracts with the shortest and longest life expectancy are circled in both panels. Does this mean that if we have someone who lives in a very deprived neighborhood and they move to a less deprived neighborhood, their cardiovascular risk decreases? We don't know that. Next slide. So the issue is a phenomenon called endogeneity. This is a famous joke about if you go into a gym, you'll find that there's a lot of healthy, fit people there. So having a gym in your neighborhood is something that promotes fitness. And of course, that's not true. People tend to live where certain features are located, and that might be one of them. So if you live next to Whole Foods or live near it, you might have some characteristics that explain your preference. Now, people in some of our poor communities don't have a choice. So community structures are critically important for health and food choice. Absolutely no question about it. So we're counteracting these individual characteristics, but people will eat what is available. And remember, convenience is an important factor, and price is an important factor. So we may not be getting past taste, but we can certainly counteract some of these forces. So neighborhood socioeconomic conditions influence cardiovascular disease, diabetes, onset and management, of course, food, retail environments. Next slide. And this is another index. There's many of these indexes around, et cetera, but this is a retail food environment, fast food restaurants and convenience stores divided by grocery stores and produce vendors. I've seen other ones that have gas stations, or I guess they would count that under convenience stores, but the higher that index, the less healthy the home food environment. And of course, they're gonna have higher rates of obesity and diabetes there. Next slide. So this gives you the REFI and RFEI. And again, the interesting thing is to look at that large swath of Southeast Ohio where there is no Trader Joe's or Whole Foods that I know of in the whole region probably. And there are many parts of it, and not that Whole Foods is a marker of health, but it's a marker of an affluent community that may be more interested in healthier food. But anyway, you see this large swath of it. And of course, there are areas you can see outside of our major metropolitan areas. You look out north of Columbus and away from Cincinnati, away from Cleveland, you'll see lots of retail deprivation. Next slide. No, I think we got to go forward. Rick? So this is a study that Adam included from South Africa. Difficult for me to eat healthy because the stores are so far, so I have to spend money on transport. The spas I shop do not sell healthy food. Even the distance to such water is too far. Now, most Americans don't face these barriers to healthy food eating, but I think this quote kind of illustrates it. To get to places is more difficult. There's a lot of study, a lot of use of the term food deserts, which has finally gone out of favor. Actually, based on a study from Chicago that showed that within the city of Chicago, within 1 mile, you can get anything you want. And that very, very few people shop for food where they happen to eat. They'll come back on the way from work, they'll on the way back from school, etc. So a food desert is a very, very difficult thing to design. And the approach now is looking, tracking and geo-tracking, et cetera, of people to see how they shop. But this is a tough example of some of the things that people might face in other parts of the world. Next slide. And this deals with the same quote from South Africa about street vendors. I spent a couple weeks in Lyon, France, 2019. And the normal course of events is to get up early in the morning and go to the market and buy what you need. It's a pretty different environment. They have large supermarkets and things like Costco, et cetera, but people don't use them nearly as much. And of course, if we had that system here, it would make a big difference in the way that people eat. Next slide. So food environments near home and school are related to consumption of soda and fast food. They consume more soda, they consume more fast food, etc. Again, very difficult to tease out what's going on. If you replace all the food in a community with healthy food, will people actually consume healthy food, or will they leave the community to buy food? And that was certainly the experience in Illinois when we tried to tax soda. The people who really like their soda would step out of Cook County and buy it just across the line so they could save themselves a little bit of money. So you have to be very careful about that phenomenon as well. Next slide. And differences can be hyperlocal. I think the point of Adam's slide here is that it's not so simple as to talk about just the neighborhood environment. So there's perception of healthy eating identity, which is really important. People who perceive themselves as valuing healthy eating and to eat healthier, social support, as well as neighborhood characteristics. All of this influences healthy eating scores. And these differences are significant in different cities. So he has Cleveland here, next slide. Columbus as well, which is a significantly healthier city in this regard that has more resources for healthy eating. And of course, the identity of folks may be similar, but it tells you that the differences can be hyperlocal and that there are interactions among all of these terms that determine how we eat. Next slide. So improvement is possible is the lesson. It sounds like we're fighting a losing battle. So efforts to improve healthy food availability and reduce costs are generally, so they're very, very small improvements. And I don't think that means that we should not be advocates for them. However, we have to recognize that true solutions, I think, to how people eat have to do with a lot of their own individual motivation. It has to do with health and food policy. People probably know this, but the amount of sugar in cornflakes is reduced, I think, 1 or 2%, something like that, every single year. If they dropped it by 30% in 1 year, kids would stop eating it right away. Similar products, there are yogurt products where there's a threshold where you keep dropping the sugar and the kid suddenly pushes it away, but you want to stay slightly above the threshold for a few years and start to change it. Jackson Wright had pointed out that the amount of salt in foods in Britain is quite heavily regulated now, but they didn't do it all at once. They drop it slightly every single year, and they've seen improvements, for example, in the incidence of stroke. So that has to do with policy. Then there are other things, partnerships between clinics, community members, and retail groups, farmers market generally met with a positive community response and shows some improvement. Certainly in terms of engaging communities and to tell them what healthy food is all about is a really, really useful, that's a really useful mechanism. So activity-based understanding of the food environment, and this is exactly what I was talking about, are needed. You do not talk about food deserts as if people only buy their food from there. They have been engaged in different aspects of their work and educational environment, and therefore purchase food from a number of different sources. Next slide. And again, this is a model by Shiriki Kumanika, which I remember having some knowledge of. So there's many different things that we would need. So increasing healthy options is only one of those, right? Reducing deterrence to healthy behaviors, that's the whole idea of making the healthy choice the easy choice. Even placement from the behavioral economic standpoint, if you go through a cafeteria line and you put the healthy items in the most convenient locations, people are more likely to choose them. The process I think I'm very excited about is empowering communities and asking communities, especially at this time when social justice has become so important, to really start to think about what am I eating and putting in my body? Who's selling it to me? And what are the consequences of it? And can I take a stand? Is something I think that is another approach that may prove promising in the long term. Next slide. Okay, thank you very much. I think we got through it in 25 minutes, Kathleen, so we can take some questions. I will do my best to answer some questions about Adam's portion if I can.
Thank you, Goutham. That was wonderful. I think that it's just so interesting to really think about this in a way that takes into account how much we could or could not change people's food preferences, and bring the horse to water, but you can't make them drink. One of the interventions that one of our diabetes educators at OSU has been trying to implement is this program called Cooking Matters, where you bring, in our case it's type 2 diabetes, but it could be for kind of any purpose, and you teach them how to affordably cook healthy foods. What are your thoughts on that?
Yeah, so most people don't cook. I just think that it's tone deaf to some extent for me as a physician, or Kathleen or any of us, to say, well, here's a set of healthy recipes you can make for somebody that doesn't cook, doesn't have the time or skills or the raw ingredients to do so. So I was involved in something with the American Heart Association called Healthy Cooking by Heart, and I actually developed some of the modules. And the underlying theme is not that you're going to go out and start cooking like crazy. It's like people who watch cooking shows, many of them have never turned their stove on, kind of thing. But it's not that you're going to go out and cook, but you will have some idea where food comes from and what it should taste like and what healthy cooking is. So it's more of an educational thing. So the next time you choose fast food, you're going to say, well, wait a second, maybe I'll choose something healthier. So the goals have to be pretty clear as well. But we also have to be very careful. It's kind of like, the thing that I always ask the nutritionists I used to work with to avoid saying is, it's pretty easy to cut back. This is what I do for exercise. This is how I eat. That doesn't come across well to a lot of our patients. Great question, though.
Yeah.
There's a lot of comments. I'm going to go through these very quickly so we can get to our interesting cases today. There's so many that I may not, if I miss it. David Aaron has a question: longevity plan by John Day and Jane Day, Cardiology, Intermountain. I have not read that, David, but we'll certainly look it up after this. It's about a village in China where people live, many of them live to be greater than 100. Chris has some points, dichotomizes food as outlets as healthy and unhealthy. Absolutely true. Whole Foods still says a lot of junk. It takes a lot of education to overcome food marketing. Food marketing is a huge, hundreds of billions of dollar industry. And in our Chicago Childhood Obesity Echo, which I run alongside this one, we find that in some grocery stores in Chicago, there were 100 different soft drinks marketed exclusively to Mexican Americans, 100 different varieties of them, many of them imported. And how do you counteract that? It's not so easy. Chris had a point about the yogurt industry. Yes, there has been modest reduction in sugar without any policy. Some of that is motivated by the Class B or benefit corporation designation. So I've already disclosed to you what company that I deal with, but there's only 2 large Class B companies in the United States operating. One is the Dannon company that makes yogurt. So Class B refers to health, environmental sustainability, social justice, etc. Any guesses as to what the other company is? Not that you should go out and buy their products, but you're not going to get it, don't worry. It's Patagonia, the clothing company is the other one. That's it. And hopefully there'll be more in the next few years. Amy Milligan, we have some local ministries that are doing crock-pot meals. Very good. Liz has, as a former grocery store dietitian, this is a perfect example where a grocery store tours to take place, showing yes, absolutely. So the point of those types of programs is not to influence eating and health necessarily in the short term. It's to help people understand what healthy eating and what healthy food are, and hopefully that there is a social justice aspect to it as well. Okay, thanks very much. I think, Kathleen, we need to move on.
Yes, let's move on to our case. That's a really great case, Amy, and certainly very challenging. I guess the one comment that I would have is there is this really interesting relationship between hypoglycemia and really just the opioid receptor effects. So basically, hypoglycemia, like other kinds of acute stressors, can stimulate the opioid receptors in the brain, and that actually has an effect of reduced hypoglycemia, reduced awareness of hypoglycemia, and it kind of impairs the counter-regulatory response. So you're very right to be, very cautious about using insulin. And it may be very true that she could have some pancreatic atrophy from whatever reason. And it might be worth getting a C-peptide level. And if you wanted to allow her to have those syringes, I would agree with, at least trying to switch to an insulin that's going to cause less hypoglycemia, whether that's glargine or Levemir, because I think that's a big hurdle for her down the road. The other piece then, of course, is if you're having an opioid, crisis of such, and just not eating as well, that if those are kind of unpredictable, that can also, of course, set her up for hypoglycemia. It might be worth checking a C-peptide to see where she is in that regard.
Yeah, I think that's a very good point. And somebody had suggested hiring a peer support person, and that's something that we are in the process of doing, because I really realized that for me as a physician, it's challenging to engage patients who are in crisis, and I think it would come much better from somebody who's been there. And so we decided to change sort of my assistance in the medication assisted treatment program from being more sort of a coordinator and administrator to actually being sort of a more on the ground peer support person who can help get patients to meetings and really engage them when they're struggling.
Yeah, there's another comment about peer support. Okay. Anyone else have other suggestions as far as, this case, opioid use, and if there are, what are the thoughts in providing, implicitly you're providing, clean syringes with the knowledge that she probably is still using?
Yes, I figured it was, risk reduction at this point, and given the amount of infectious complications, I feel like as much as we can help prevent those, be good. I'm really worried about her, surviving another round of sepsis. The last one was pretty frightening.
Amy, does she have hepatitis C?
Oh yes, she does have hepatitis C as well. And up until now, we've never even discussed treating that because of the need to be 6 months 6 months of sobriety in Ohio. But that requirement, I'm not sure if it's overtly gone away, but it's at least gone away in terms of practicality. It's not on the prior authorization form. Right now, she seems to be coming to more appointments with us, which is a good sign. It's kind of strange during the pandemic, both physically as well as the telehealth. And so I was considering proceeding with getting a prior authorization for the medication and seeing if she would be, willing to maybe come to our office weekly so we could kind of, set up a, Mediset, make sure that she's taking it. Because studies do show that if you can reduce the Hep C, sort of prevalence, that we're probably doing a very good thing, and other, cities have experimented with that.
Mm-hmm.
We just had a grand rounds at Metro Health, and they said that 6 month requirement has been waived, I believe. I'm not sure if anyone else can second that, but I believe Medicaid would cover it.
Yes, that is our understanding. I wasn't sure really how they got to that point, because I talked to some folks earlier, maybe last year, at the top of Medicaid, and they didn't seem ready to do that. So I'm not sure if it was the pandemic or more data coming out that it's a good idea.
And Dr. Shalabi suggested also SGLT2 inhibitor, assuming she has probably Medicaid, right? And so the GLP-1 should be pretty straight, you know, I'm sure is covered, and so an SGLT2 inhibitor could be covered as well.
In terms of the question for subsidized housing, usually we have the best success if she is willing to engage in mental health treatment in terms of getting quick access. And so that's one of the reasons why I've been trying to have our behavioral health consultant reach out to her regularly to see if she would be willing to participate in our local program that allows people with significant depression and other mental health disorders get treatment. I think one of the problems is, and I haven't looked thoroughly, but I have a feeling if she wants to stay with her boyfriend, that may become an issue, because based on what she says, I suspect he has significant felony charges. And so a lot of the public health or the public, you know, the subsidized housing, that becomes a huge barrier. To my knowledge, I don't think she has any significant charges that would keep her from that. I think she has some driving under the influence, but I don't think she would, I don't think her situation would make the subsidized housing difficult, but I think her boyfriend's definitely would.
And then Dr. Shalabi also commented on the SGLT2 inhibitor risks. This might be someone who, you know, could theoretically be set up for the euglycemic DKA if she gets dehydrated, stops eating, that sort of, I think that's kind of what you're getting at, right? And that is another reason I think also to check a C-peptide, just to kind of see that people who are at risk for, you know, non-classic ketosis-prone type 2 diabetes might also be at risk for euglycemic DKA. But overall, the risk is very low. It wasn't observed in clinical trials, which are mainly in people who've had diabetes for, you know, 5 years or so. When you start seeing it more are people who are insulin requiring, have had it for a very long time. So, I mean, that might be something to consider. I think it's still probably low, but probably worth counseling her.
Amy, thank you for presenting this case, because I actually have somebody just like this I was considering presenting next week, and I'm struggling with almost the same things that you are. So thank you for doing it. I don't have any good ideas. I guess a bad idea would be, I wonder if that free breakfast has any oatmeal packets or fruit or anything like beyond the Danish. So if they actually have some healthier choices, she could stock up and stock in her pockets or not. I have no idea what they're serving at the Cincinnati hotels.
No, I think that is a very good idea. And it's nice just to know that I'm not alone, because, you know, every month or so, there's something new. And it's just sometimes hard to keep all of the different issues really in focus. Like, I didn't realize until we did this, or until I presented, that we hadn't done a retina view. But, you know, part of it is that so often her blood sugar is crazy high when she comes, and we're keeping her in the office and having her drink lots of water, and or trying to, you know, figure out what's going on with her specialist. She apparently also has Langerhans histiocytosis on both lung and bone imaging, and we haven't been able to follow up with pulmonary or heme about those. So a lot going on.
There's another comment from Jim Warner, basically talking about, you know, trying to build confidence to help with her motivation. This is a small way to get a foothold, mental health or substance use treatment.
Well, I'm kind of sad because I didn't get to let her know how excited I was that her A1C was better. The 7.3 actually came when she was following up with gynecology regarding the tubo-ovarian abscess, because we originally were worried it was ovarian cancer. And so I wanted to let her know that, you know, certainly it seems like she's taking more care of herself. I do worry about it coming with some lows. So we got a Libre approved, but surprisingly, she's a little bit hesitant about that, which we're still working on trying to figure out what I'm not, you know, kind of explore that a little bit more.
Wow, that is impressive that you got a Libre approved for BID and PH. That's wonderful.
It's, you know, thankfully we have a wonderful pharmacist who I think was able to really comment on her risk of hypoglycemic events, and just that, given everything else going on, the possibility of her checking her sugars, you know, more than once a day is often challenging.
Yeah.
Kathleen, Dr. Shalabi had a question I was kind of wondering about as well. It deals with Actos, and I have pretty much stopped using the TZDs, probably because there's so many other options available. But what do you think about that?
Yeah, I think Actos is still on the table for her. We probably use Actos a little bit less than we really should. You know, the TZDs really got a, you know, really bad rap, you know, about a decade ago. But it turns out that in part of this was a concern over differences between rosiglitazone and pioglitazone. So what we know about pioglitazone is that, yes, it is associated with increased risk of heart failure in people who are predisposed. So it does not cause myocardial dysfunction in and of itself. So it's only if you've got some other kind of structural disease or whatnot. And in fact, there's probably some data that it also might help with, you know, various types of fatty liver disease. And also now we have some data from the IRIS study that shows that in people with advanced prediabetes, that it will reduce, who present with a stroke, that it reduces the risk of recurrent stroke. So you do have to deal with the weight gain and edema, but I only use lower doses, 15 at the most 30 milligrams, especially if you've got insulin, because that can exacerbate fluid retention. And then you can think about, you know, that definitely it can cause some bone loss, but mostly in postmenopausal women. So in postmenopausal women, I might do some screening there, but it's cheap and it just takes, you have to be patient because it takes like 4 weeks to kick in. On the flip side, it'll take 4 weeks to really clear the system too. With her liver disease, I think I would be, you know, I'd want to know, like, you know, what the extent of that is. Might monitor liver, but unless she's got cirrhosis, I don't think that would be a contraindication.
Yes, her imaging in terms of her liver actually looked pretty good on her CT scan done last month. So I think that her young age female has probably protected her right now from a lot of the hepatitis C. Now it's just a question of whether we can get her engaged in treatment, and that may be one thing to build confidence, that if we can clear her clear the hepatitis C, maybe that would give her confidence to, you know, tackle one of these other issues.
Mm-hmm.
Thank you all.
Well, that was a great conversation. I think it's time now to head to our wrap up. Shannon, do you want to take over?
Absolutely. Thanks, everyone. Great clinic today. You can always watch previously recorded echo clinics on our website. You just have to register first. And finally, you've all received a survey in your emails. Please complete this by tomorrow at 5 p.m. I did receive a note that REDCap is down this evening from 6 to 7 p.m. So it may not work during those hours, during that hour, but you have until tomorrow at 5. And lastly, next week, we will start reminding you how to obtain access to CME credits if you wish to obtain them for the series. And Finally, subject to change, but next week we will have Liz Beverly from Ohio University on type 2 diabetes in a rural context. So have a great week, everyone, and we'll see you next week. Bye.
Thank you.
Bye, everyone. Bye.